Hello, everyone. This is Dr. Pritpal Singh, an MD Pharmacology from CMC Ludhiana. And today I'll be talking about the competency PH 1.4, which says describe the absorption, distribution, metabolism, and excretion of drugs. In one of my previous sessions, I had talked about absorption. Today, I'll be talking about distribution and hope I'm able to clear some of the concepts of this distribution phenomena so that it helps you get better equipped from the new CBME curriculum which has been implemented throughout the country. So when we talk about distribution, earlier we were talking about absorption, which says that the drug has to reach the circulation, and we tend to have many phenomena that help in absorption. And moving beyond that, we'll be talking about distribution. The distribution, as the term suggests, this is the process by which a drug diffuses or is transferred from the intravascular spaces to the extravascular spaces. Now, previously we were talking about drug reaching the circulation. That means it has reached the intravascular space, absorption is done. Now we need to move beyond absorption, and this drug that has reached the blood, it should be circulated throughout the body. It should reach the various extravascular spaces, and that is what the phenomena of distribution talks about. Now, whenever we give a drug, once this particular drug reaches this particular pool of blood or the plasma, this drug could exist in two forms. It could be either in the free form or the bound form. I'll be talking about the significance of the bound form of the drug. Now, this bound form of the drug stays inside the plasma pool, whereas the free drug that is available, it could move to the site of action, it could move to the storage tissue, or it could even go to the other tissues. So this particular free drug is available, or free drug is a drug that reaches all this thing. Now, depending upon, there are certain factors on which distribution depends, and these factors would be lipid solubility. Lipid soluble, a drug that is highly lipid soluble would be distributed throughout the body. It would easily cross all the membranes. It would reach all the extravascular spaces, whereas a water soluble drug would stay in the vascular compartment only. Similarly, ionization at physiological pH, ionization renders a drug water soluble, and hence it stays in that particular compartment. And then we have plasma protein binding, which I was talking about, the drug existing in free form and the bound form. So this particular plasma protein keeps the drug in the bound form and it stays in the blood. And then we were talking about tissue bindings, and another factor that tends to uh, increase or decrease distribution is the regional blood flow. Now, how this particular regional blood flow helps in it it will be quite obvious with the help of phenomena of redistribution. So before we look into this particular phenomena of distribution, we need to talk about the body fluid compartments, and we say that 60% of the body weight is fluid. And when we talk about a 70 kg person, that means around 42 liters of the body weight is fluid, out of which 2/3 is there in the intracellular spaces and 1/3 is there in the extracellular spaces. Out of this 1/3, 3 to 5 liters of this fluid is in the plasma in the form of blood, and rest 14 liters is in the ESF, and majority of 2/3 of the fluid is in the intracellular fluid. How does this help? So this 3 liter or this 5 liter of plasma is the compartment from which a drug is distributed. A lipid soluble drug, as depicted by green arrows, could go to all the sites. It could reach almost everywhere. Whereas water soluble drug, as shown by white arrows, is mainly restricted to this extracellular compartment only. It will not be able to cross these extracellular compartments because of the plasma membrane that are there in the various cells that does not let it easily go through the various cells. Now, before we go into further details of the distribution, what we need to do is we need to have some assumptions. And one of the assumption is that we need to consider body as a single homogeneous compartment which has a volume V. Now, what is the significance of this? Let's see. So this volume V helps us determine the volume of distribution of the drug. So this volume of distribution is depicted by dose administered over plasma concentration. And this is known as apparent volume. Why apparent? Because I just told you that we are assuming body to be a single homogeneous compartment, which is not true. So when we calculate this apparent volume of distribution, it says that it is the volume that would accommodate all the drug in the body if the concentration was same as in plasma. So, or it is, or let's put it other way around, it is a theoretical size of which is available into body for to contain the concentration same as in plasma. So volume of distribution would depend upon lipid solubility. A drug that has a higher lipid solubility has a higher volume of distribution. Lipid insoluble drug would mainly remain in the extracellular fluid and hence would have a low volume of distribution. Plasma protein binding would lead to a very low volume of distribution as depicted by warfarin, which has a volume of distribution of 0.15 liters per kg. If there's tissue binding of any drug that has a very high volume of distribution, such as cases digoxin, then this volume of different distribution could also depend on the differences in regional blood flow as well as certain disease states like congestive heart failure, cirrhosis, and uremia. Now, how does this apparent volume of distribution helps us? This apparent volume of distribution helps us to determine the loading dose. Now, what is this loading dose? Loading dose is the dose that is required for initial action of the drug. So what needs to be done is we need to fill all the sites so that the drug reaches its site of action and it is able to have its action. And it could also help in estimating blood concentration of the drug for the treatment of overdose. What I told you that a drug that has a volume of distribution equivalent to plasma volume, that drug will stay in the plasma, and once hemodialysis is done, it can be removed. A drug with a high volume of distribution means that this particular drug is uh, getting accumulated in certain tissues and there is no use of hemodialysis. Similarly, a very low volume of distribution depicts that there is a high amount of plasma protein binding and there would be limited utility of hemodialysis. Now let's talk about another phenomena that is there in distribution, that is redistribution. Now this is one phenomena which tells us about or which depicts the lipid solubility of the drug. A drug that has or a drug that is highly lipid soluble, what it will do is once you inject this particular drug, it will immediately reach to those organs that have a high blood flow, namely the brain, the heart, and the kidney. Because of its high lipid solubility, as soon as it enters the brain, heart, and kidney, immediately it comes out because of the phenomena of diffusion. And then it reaches the organ with less blood flow and more bulky tissues such as muscles and fat. So this is redistribution, drug reaching the initial organs with high blood supply, then to the lesser blood flow. So this is redistribution of a drug. And the clinical utility of this is depicted when we give thiopentone sodium, which is a highly lipid soluble drug for induction of anesthesia. As soon as this drug is given, injected IV, it immediately reaches the brain, heart, and kidney and causes action. But because it is at the same time, it is gets removed from these organs, so the action is terminated very quickly. This is the significance of redistribution. Another particular property or that depicts distribution is the blood-brain barrier, the BBB. Now, when we look into the differences between the blood capillaries and the brain capillaries, what you found out here is that there are some loose junctions out here. These loose junctions allow easy access of drug. As compared to the brain capillaries, there are tighter junctions. That is one point. And then there are a layer of glial cells that prevent entry of drugs. So that means only lipid soluble drugs can easily cross the blood-brain barrier, whereas water-soluble drugs will not be able to cross the blood-brain barrier and will not reach the brain. And that is one of the properties that is seen when we give levodopa. Levodopa, being lipid soluble, easily enters the brain and is converted to dopamine, whereas dopamine does not enter the brain and is of no utility or limited utility, or in cases of Parkinsonism. Then there are certain areas where this blood-brain barrier is deficit. One certain area is the chemoreceptor trigger zone, which is located in the medulla oblongata and certain periventricular sites. So any drug that stimulates the chemoreceptor trigger zone induces nausea and vomiting. And this being outside the blood-brain barrier, it is independent of the lipid solubility or water solubility of the drug. There are factors that can lower the blood-brain barrier and increase the permeability, such as injury. Now, this injury could be due to trauma, it could be due to ischemia, it could be due to inflammation, or it could be due to pressure. There could be infections such as meningitis, there could be hyperosmolality, or microwaves or radiation, which could lead to a increased permeability of blood-brain barrier. Now, it is not only the cells that maintain the blood-brain barrier, we have even enzymatic blood-brain barrier, where there are certain enzymes that are present in the capillary walls or cell linings, such as monoamine oxidase, which is responsible for the breakdown of catecholamines as well as serotonin, and cholinesterase, which is responsible for the breakdown of acetylcholine, so that these substrates do not accumulate excessively in the brain, leading to certain effects. Then another barrier that is there that we need to talk about is the placental barrier. Obviously, everything holds true that any drug that is lipid soluble can easily cross the placenta. But this placental barrier is an incomplete barrier. So even the non-lipid soluble drugs can cross in high concentration if they are given for prolonged duration, and it could easily reach the fetus, thereby causing harm to the fetus. So this placental barrier is an incomplete barrier, and almost any drug could pass through it. So the significance of this is that in pregnancy, all the drugs are contraindicated unless their safety is proved. Now we come to one more phenomena that I was talking about, the bound drug. Now the bound drug is referred to as plasma protein binding. Now there are two group of proteins that bind to drugs. One is the acidic proteins, the other one is one basic proteins. So the acidic drug binds to the basic proteins such as plasma albumin, the example being barbiturates, penicillin and NSAIDs, whereas basic drug binds to alpha-1 acid glycoproteins such as quinidine and beta blocker. Now, the extent of this depends on an individual compound, and once we increase the concentration, the saturation site gets saturated, and more of free drug would be available. That could lead to toxicity. So, the significance of plasma protein binding. So the first thing is that the bound fraction is in equilibrium with the free fraction. That means if 99% of the drug is bound and 1% is free, then that is available for action. So at all times, there would be 1% of drug that would be free and 99% would be bound. So once this particular drug is bound, that means that this particular drug will not be able or will not cross the glomerular filtration barrier, or it will not cross the basement membrane. So this particular drug will be longer acting. Only the free drug would be able to cross this membrane and will be excreted out. Then the bound drug would be released similarly in the same as equilibrium is maintained. And other thing is, any drug that is highly plasma protein bound is mainly restricted to vascular compartment and has a low volume of distribution, as I told you earlier. And whenever we are talking about expressing the concentration of a drug, the concentration of the drug refers to both the bound form as well as the free form of the drug. It is a combined of both expressed in the free form. And the another clinical significance is displacement interaction, though clinically not frequently seen, but still, if supposedly two drugs bite for the same site of action, there is all possibility that one drug could displace the other, as in case of phenytoin, which displaces warfarin. Now, these plasma proteins could be altered in certain disease situations in pregnancy. So if there is a hyperalbuminemia, so then there is obviously albumin is less, and you'll have more number of acidic drugs. Uremia, again, acidic drugs. Pregnancy, there is an increase in plasma proteins. Inflammatory disorders, there's an increase in alpha 1 acid glycoprotein that could vary the amount of plasma protein bound. The other thing that is there is the tissue binding, where depending upon the affinity of a tissue to a particular drug, the drug gets accumulated in a particular tissue that is differentially distributed. And once a drug is bound to the tissue, it has a large volume of duration, and it is comparatively longer acting. So this is responsible for local toxicity, such as seen in tetracycline, which gets deposited in the bones and teeth, and chloroquine, which gets deposited in the retina. Now, how this happens, it binds to the specific organelles in the cell. So this is regarding certain properties or certain phenomena that are there in distribution, where we start with the apparent volume of distribution. We discuss the redistribution. Then we talked about the blood-brain barrier, the placental barrier, and we talked about the plasma protein binding and tissue binding. So this is all regarding the phenomena of distribution. And in the subsequent coming sessions, we would be talking about metabolism as well as excretion. I hope I have been able to give some clarity on this particular topic. If there is any further queries regarding this particular topic, you could easily send a message in the inbox, and I would definitely get back to you. So wishing you a happy learning and a nice day ahead. Thank you so much for your hearing.